Yes, sir.
Hmm.
Good evening, sir. The topic for today
Okay.
is on new oral anticoagulants and anesthesia, sir. So
Hmm.
to start with an introduction, so anticoagulation is an essential in conditions like atrial fibrillation, venous thromboembolism, and prosthetic valves. And usually we use warfarin, which has several limitations, like it has a narrow therapeutic index. Also, the need for continuous INR monitoring, and there are multiple interactions with these drugs. So the newer oral anticoagulants, which are also known as the direct oral anticoagulants, uh, have a predictable pharmacology, also a fixed dosing, and fewer interactions. To start with the classification, these are basically broadly classified into direct thrombin inhibitor, which is dabigatran, and the factor 10A inhibitors, which are rivaroxaban, apixaban, edoxaban, and okay, less commonly used betrixaban. The pharmacology of these drugs include the dabigatran targets the thrombin 2A, which has a half-life of about 12 to 17 hours, and it is 80% renally excreted, and usually it has to be avoided in renal failure patients. The rivaroxaban, apixaban, and endoxaban target the 10A molecule, and these are around 11 to 13 hours of approximately average of 12 hours of half-life, and these are both renal and hepatic eliminated, and exception of endoxaban, which is mainly renal, and all these drugs can be given once daily, and should be given twice daily. The advantages of these drugs over warfarin include a rapid onset of action and offset of action, no routine INR monitoring, fixed dosing is prefixed dosing, and there are very few food or drug interactions with these drugs, and there are a lower risk of intracranial hemorrhage noted with these drugs. The preoperative management in elective surgery, the timing depends on the renal function and also the bleeding risk of the surgery. So if it is going to be a low risk surgery, for example, hernia or cataract, then we can hold these drugs for at least 24 hours. And for any major surgeries like the high risk surgeries or neuraxial ortho or cardiac neurosurgeries, the drug has to be held for at least 48 hours, preferably 72 hours according to the ASTRA guidelines. In case of an emergency surgery or trauma, the drugs has to be stopped as early as possible or as soon as possible, and the surgery has to be delayed if possible to at least more than 12 or 12 to 24 hours after the last dose. And the renal function has to be assessed for these patients in order to check for the clearance. And if available, the reversal agents has to be administered. For dabigatran, it's idarucizumab, and for factor 10A inhibitors, it's andixanet alpha. And if both these drugs are not available, then four factor PCCs has to be provided before taking up for the surgeries. And restarting after the in the post-op period include for low bleeding risk surgeries after 24 hours can be started, and for any high risk or neuraxial, then 48 to 72 hours after surgery is recommended, and at least 6 hours after epidural catheter removal has to be done. In the context of regional anesthesia, the main concern is going to be the spinal or epidural hematoma, where the ASRA or the ASRA guidelines states that the drug has to be stopped at least 72 hours prior to the neuraxial procedure, and for any removal of a catheter only after appropriate interval, which is also going to be more than 48 hours after the last dose. And the restarting of the drugs can be done after at least 6 hours after the catheter removal. And if inadequate interval is present, then it's better to avoid neuraxial anesthesia and prefer a general anesthesia in these patients. So the anesthetic considerations are going to be mainly on careful history as when the patient has taken the last dose, assess the renal and hepatic function in these patients, and plan the timing of surgery or renal blocks or regional blocks, and minimize the other drugs which increase the risk of bleeding in these patients, includes the NSAIDs and the antiplatelets. And for high risk patients, these intraoperative blood conservation strategies or cell salvage has to be considered. And in emergencies, any the reversal agents or the PCC has to be administered if needed. So on conclusion, these are increasingly used to predict with the use of predictable pharmacology and the ease of administration, and we need to take care of the timing of discontinuation and resumption. in especially with the regional anesthesia to prevent the spinal hematoma in these patients. Thank you, sir. Excuse me, sir.
Not able to hear it.
So we are not able to hear you, sir.